Good morning, good afternoon, and welcome to everyone joining us from around the globe for our latest installment of the ClearPoint TV peer-to-peer webinar series. My name is Rob Rubio, and as a representative of our entire neuromodulation navigation team here at ClearPoint Neuro, it is a pleasure to introduce today's speaker, Dr. Jon T. Willie. Before we get started, I just wanted to take a quick moment to say there will be a Q&A session following with questions from the audience following Dr. Willie's prepared talk. You can submit your questions real time to us via the chat function so we can queue them up and have them ready as Q&A begins. And please stay with us until the end as we wrap up the event, as we'll be announcing the first in a series of new and free reference compendia for anyone interested in targeting the ANT with image guidance. But now to introduce Dr. Willie. Dr. Jon Willie is an associate professor of neurological surgery, neurology, and neuroscience, director of stereotactic, functional, and epilepsy surgery, and director of the Laboratory for Behavioral Neuromodulation at Washington University in St. Louis. Dr. Willie obtained his BA in biochemistry with honors from the University of Texas at Austin, and his medical doctorate and PhD in biomedical sciences from the University of Texas Southwestern in Dallas, where his graduate work focused on elucidating the fundamental role of the neuropeptide orexin in the sleep disorder narcolepsy. He completed his neurosurgery residency at Washington University in St. Louis and his fellowship in stereotactic, functional, and epilepsy surgery at Emory University in Atlanta. He practiced as a neurosurgeon scientist at Emory University for 9 years, where he developed a robust clinical practice, secured funding from private foundations and the National Institutes of Mental Health, and contributed high-profile clinical, neurosurgical, and basic neuroscience publications. During his time at Emory, Dr. Willie was among the very first in the world to introduce ClearPoint MRI guidance into a high-volume neurosurgical practice. To date, he has performed over 125 ClearPoint-enabled procedures since 2010. He has co-authored 6 peer-reviewed publications examining ClearPoint's efficacy and various techniques, including an upcoming paper comparing the accuracy of ROSA robotics and MRI-guided ClearPoint in corpus callosotomy. And he was among the very first in the world to use direct MRI guidance for thalamic stimulation in epilepsy. Dr. Willie recently returned to Washington University in 2020. His laboratory investigates the enhancement of memory by brain stimulation and development of novel interventions for epilepsy, post-traumatic stress disorder, and sleep disorders. So with that, I'll hand it off to Dr. Willie as we look forward to what he has to share with us today.
All right, so thank you for the introduction. I'll be speaking about direct targeting of the thalamus for epilepsy using interventional or intraoperative MRI. These are my disclosures. Most relevant is that is for ClearPoint and Medtronic, and also I'll mention NeuroPace. Again, this is my disclosure. These are my own independent opinions, and I had full control over everything that I'm presenting today. So starting just with a patient scenario, this is an example of a patient, 40 years old, adult onset seizures at age 31. She worked as a pharmacist, but has since lost her job. Basically, first hinted some cognitive impairment. She has an MRI, which is essentially normal, but in particular, the hippocampi are normal. A PET scan that suggests bilateral temporal lobe hypometabolism. She has a scalp video EEG study, which shows bilateral spikes, bilateral temporal lobe focal impaired awareness seizures, and she does have frequent generalization of these seizures. Her neuropsychological evaluation shows evidence of bilateral memory decline. So she underwent an SEG study, which revealed bilateral temporal onsets with broader multifocal onset and these were poorly localized. So although this appeared to be bilateral temporal lobe seizures, it was not clear cut that these were just hippocampal seizures per se. So this brings up a treatment algorithm that Bob Gross and I developed at Emory and that we've been using along these lines for treating temporal lobe epilepsy. Increasingly, as we no longer just do temporal lobectomies or even selective amygdalohippocampectomies anymore, as we have laser interstitial thermal therapy and a variety of neuromodulation techniques, it's becoming more necessary to think about these patients in an algorithmic way. Although algorithms, only go so far, individual patients always require individual decision making. But in general, for straightforward mesial temporal lobe sclerosis, depending on the dominance the side. Usually in non-dominant, we consider offering laser interstitial thermal therapy or a selective amygdalohippocampectomy. For the dominant side, we almost never offer anything other than laser interstitial thermal therapy, at least as a first attempt. Our own group data at Emory has suggested that the collateral damage that occurs to the remaining temporal lobe in the setting of mesial temporal sclerosis provides or causes more additional neuropsychological risk relative to the benefit. So on the dominant side, for sclerosis, we always offer lit first. For non-straightforward sclerosis, we often investigate with SEEG. Now, what I mean by that is when there's discordant information, the temporal, either the EEG or the PET scan or the neuropsychological evaluations don't provide direct concordance with the sclerosis on the MRI scan. So there are additional questions. In those settings, we will often do SEEG. But again, we may come up with the same sort of algorithm for what we do with that information. If it's coming from the non-dominant side, we can consider either laser or a selective amygdalohippocampectomy if it's localized to the hippocampus. For the dominant side, again, we would prefer to do laser interstitial thermal therapy. For non-MTS or MRI normal MTLE, of course, all those cases, we don't know for sure that our seizure onset is the hippocampus. In those cases, we do SEEG in order to investigate the onset. And often we're looking for ultimately being able to ablate or remove the epileptic focus. And again, if this is turning out to be hippocampal in origin, for non-dominant, especially in MRI normal cases, we recommend doing a laser interstitial thermal therapy versus the reason this almost seems counterintuitive, but we either do laser to spare all that lateral temporal lobe function and focus on the hippocampus, or given that it's non-dominant and tolerable, we don't do a selective open surgery, we do an anterior temporal lobectomy, because often what's found is that the best outcomes for these MRI normal cases is a broader resection, and we feel that to be more neuropsychologically tolerable on the non-dominant side. However, on the dominant side, we see that there's a lot more risk to verbal memory. In the case of a dominant onset, or if there's bilateral onsets, we're concerned about risk of amnesia. If it's multifocal or frontal temporal, these are the cases that are difficult to say, well, we should do an open resection or laser ablation. And this feeds into strategies related to neuromodulation. So then the next component of the question is, well, was it localizable based on SEEG? If it is localizable, we often consider responsive neurostimulation and neuropace, especially if it's localizable to the hippocampus or localizable to some specific neocortical focus. 1 to 2 foci, we would do RNS, but failing that or other patient preferences, we might consider deep brain stimulation. If it is not localizable or it's multifocal greater than 2 foci, then really neuropace may not be the most appropriate initial strategy. And so those are cases where they've either had vagus nerve stimulation already or choose the least invasive option and pick vagus nerve stimulation. But failing that, we would take those patients to deep brain stimulation. So what is the rationale? Anterior nucleus of the thalamus stimulation, the concept has been around for quite a while, developed in the 80s, studied in animal models, several clinical series came out over time. But the idea of this comes out of our thinking about the circuits related to the hippocampus and the limbic system, the so-called PAPES circuit or the limbic circuitry. And the idea being that this circuit of the hippocampus, the fornix, to the mammillary bodies, and then that projecting to the anterior nucleus of the thalamus, which then projects back out to and communicates with especially the medial frontal lobe, the anterior frontal lobe, and then there's a circuit of information that comes back and feeds back into the temporal lobe. So that's a greatly oversimplified circuit, but the notion being that if there's a target or a node for neuromodulation in the circuit, it could be somewhere along here, and the anterior nucleus would be one potential place for intervention. So that was investigated in animals and ultimately in people, and then culminated eventually in a clinical trial. So again, the anterior nucleus of the thalamus, this is an oversimplification. This suggests that the mammillothalamic tract is directed one way and feeding into the anterior nucleus. Of course, that is a major input into the anterior nucleus. There are other inputs, and also information from the anterior nucleus can flow back into the mammillothalamic tract or back to the mammillary bodies. But this notion of a circuit where information is beginning in the mesial temporal structures, communicated via the fornix to the mammillary bodies, That information, after processing in the hypothalamus, is processed then into the thalamus, the anterior nucleus. Then that projects back out to the frontal lobe, especially the cingulate, the retrosplenial area, and then back into the parahippocampal and hippocampal structures, and therefore you get a circuit. Again, a simplification. There are parallel circuits between the amygdala, the stria medullaris, back to the thalamus, but this is the general notion that this anterior nucleus could be a node for modulation of what's going on in this circuit. So again, making this even more complex, the anterior nucleus of the thalamus has different components that probably have involvement in different aspects of hippocampal function and memory. So this is an example of some thinking along these lines, that there's an anteromedial, an anteroventral, and an anterodorsal components of the anterior nucleus, and these may have different effects on different aspects of circuits related to memory, but you can see that for the most part, they're in parallel with each other in these circuits. So this is just a non-exhaustive review of some of the clinical series that came out leading up to the 2010 Sante trial that was sponsored by the pivotal trial sponsored by Medtronic, but a number of small series of anywhere from 3 to 6 patients that got deep brain stimulation targeting the anterior nucleus. Of course, not all these studies are the same in how they chose to target the anterior nucleus or what exactly they were targeting. There's a lot of probably devil in the details that we don't, that has developed over time. We have a better understanding now of what has resulted in the best outcomes. But these early results were promising for the most part, and these case series suggested that we could potentially reduce seizure frequency. Then, of course, there was the pivotal trial sponsored by Medtronic, the Sante trial, and that was 110 patients with a median seizure reduction of 56% at the initial time point of 3 months. This is the data from that trial. So patients were implanted and then were either sham stimulated or actively stimulated during the blinded phase. There are well-known, anecdotally described insertional effects of DBS to this target. So it's not uncommon to see transient benefits from just putting the leads into this location. That may suggest there are other reasons to think about this, but you can see even in the sham group, there was a reduction in seizures. And just as these curves were starting to separate between the stimulated versus the unstimulated, then we went into the unblinded phase. And you can see even those patients that had been getting sham stimulation can recover that benefit and seeing reduction in seizures over time. This is data out to 7 years. I believe there's data out to 9 years now. I don't have that on here, but this is the source of this is from Medtronic. And this is the data analyzed in a couple different ways with intent to treat in patients that had complete data versus those patients where one thing we have to worry about is biases, where patients are in a study but fall out of the study for various reasons, but are not included in the outcomes. Presumably those patients are a failure in some way or another. So analyzing that data, either way, we see that nevertheless, we're seeing that there's cumulative benefit of this therapy over time and seems to accumulate more and more year after year, which is a pattern we see again and again with other neuromodulation strategies, including VNS and NeuroPace. This is a sort of tornado plot of individual responses from the 7-year data. You can see by and far most patients have a response in which the seizures are reduced. You can see many patients are actually essentially seizure-free as long as stimulation therapy is on. I've seen this myself in my own clinical experience. You can also see some rare patients seem to have a worsening seizure status. Again, I think we've learned a lot about, since the initial pivotal trial, about how to place these leads. So I don't think we see this that often anymore, but nevertheless, attention to this is important. We certainly wouldn't want to be doing something that worsens patients, but this is probably stimulation parameter dependent. In terms of subgroup analysis, again, this is the data from Medtronic in their long-term Sante, but in the temporal lobe at 1 year, 5 years, and 7 years, it is increasingly beneficial. In the frontal lobe, we also see benefits. So even though we think of this circuit as targeting the temporal lobes, of course, as I mentioned, part of the circuit is the medial frontal lobes. And so this does appear to have benefits for patients even with frontal lobe epilepsy. This requires further investigation in types of patients that may be benefiting from this sort of therapy. But so far with the data we have, both frontal lobe and temporal lobe patients can benefit. It's a little bit more hit or miss with a smaller amount of data that's available for patients that did not meet those categories. Notably, patients that have had prior vagus nerve stimulation can still benefit from stimulation of the anterior nucleus. And in fact, in my own practice, often those patients that are coming for DBS have already failed VNS or have had partial benefits from VNS. So having insufficient benefits from one neuromodulation strategy does not necessarily rule you out from the potential benefiting from another neuromodulation strategy. And I know NeuroPace and probably other groups are looking at the cumulative benefits of these various therapies together. So you can see here, prior VNS versus no prior VNS, the response rates look relatively similar. Also, patients that have failed prior surgeries. So several of the patients that underwent deep brain stimulation of the anterior nucleus, my own practice, before and after the approval, were patients that came to me having had a temporal lobectomy already at some earlier point and did not maintain seizure freedom. So either seizures were poorly localized, temporal lobectomy didn't help, or they were multifocal, turned out to be having now contralateral seizures, various situations. But patients that have had prior surgery prior resections can still benefit from neuromodulation strategies. This is a busy slide showing the long-term neuropsychological outcomes for the Santé cohort. But on the whole, I think what to look at here is there were several statistically significant improvements in various neuropsychological parameters. Nothing was statistically disimproved overall. So the overall message here was that chronic stimulation of the anterior nucleus of the thalamus is not as a group causing cognitive problems. That does not mean that in individual patients there couldn't be changes in mood or cognition that need to be addressed with changes in stimulation parameters such as reduction. But overall, the cohort did very, very well. And this may probably reflect the improvements in seizures. So the post-approval FDA labeling for anterior nucleus of the thalamus DBS candidates are patients that are greater than 18 years of age. That doesn't mean it isn't used off-label in children, but this is the labeling. Refractory to two or more medications, difficult to localize or multifocal, focal, and secondarily generalizing seizures. So the labeling does not say frontal or temporal. It's just that our hypothesis was such that we expected this to work best in patients with difficult to localize or multifocal frontal and or temporal lobe epilepsy, but the labeling doesn't dictate that. Patients must be willing and able to undergo programming visits. So the types of patients we end up commonly treating with ANT DBS are multifocal, bilateral, or difficult to localize, especially temporal or frontal lobe seizures. And suboptimal response to previous resection and or vagus nerve stimulation or RNS. So one of the points I want to stress is that if you've been doing DBS for movement disorders, this is not the same thing. Anterior nucleus of the thalamus DBS for epilepsy is unique in a couple respects. For one thing, there isn't a consensus coordinate like we have a consensus coordinate for the subthalamic nucleus. The value of microelectrode recording has not been established. So that means that, yes, we can drop a microelectrode record and know that we're getting thalamic activity, but that doesn't necessarily distinguish what's the therapeutic target versus a different part of the thalamus. There's not really a role for intraoperative mapping of thresholds for benefits or side effects, other than, again, knowing you're in the thalamus and not in the ventricle. But it's not necessary to do stimulation to determine that. And of course, these patients having epilepsy, we usually are not comfortable with the idea of having them awake to do DBS. The value of having an awake patient in a movement disorder patient is obvious because you're looking for tremor benefits and checking for motor thresholds and so forth. Those things don't play a role in this particular target, and having a patient that can have seizures awake in the operating room is not ideal. So this is basically a sleep DBS under anesthesia. Another important aspect of this is at least the way most of this has been done, because the anterior nucleus is sitting on top of the thalamus facing the ventricle. The most typical way that people have been getting to this is a transventricular trajectory passing between the deep cerebral veins that are sitting on top of the thalamus. So there are risks of deflecting off the thalamus and into the ventricle. There's a risk that if the lead is not buried enough, it could actually back out and fall back into the ventricle. Then, of course, as you're passing through the ventricle, there could be risks of intraventricular hemorrhage. So other people have found different ways of solving this problem. The Mayo Group in particular likes to do a target that comes from the parietal boss and does not travel through the ventricle. But I'll come back to that. There may be advantages to that in avoiding some of these risks, but there may also be disadvantages in terms of actually getting the electrodes where you want them in terms of accuracy and a lot of electrode coverage. But I would say that that is not settled. The company, Medtronic itself, would recommend, I think, a transventricular trajectory, just given the amount of data that we have on that. Lead placement has some potentially complex considerations. We're positioning it to influence ANT input and output, and I'll come back to that again in a minute. The contact locations, we want the electrode to be in a particular location to provide stimulation. I'll come back to why that is in a second. But increasingly, we may also be interested in recording from these electrodes in the thalamus, either in a closed loop way, such as with a NeuroPace device, or recording local field potential with Medtronic's Percept device. So there may be reasons one wants to record local field potentials or closed loop information in epilepsy patients. So as we place these electrodes, we may want to consider which electrodes would be used for stimulation, which electrodes would be used for recording, and making sure that those contacts are in locations where we want them to be. So all of this is to say that there is a need for reliable intraoperative imaging in order to do this surgery and optimize results. So this is just in copy from the atlas I have sitting on my shelf, Atlas of Human Brain by Mai et al., which is the 4th edition is a really nice atlas. But this is at MNI consensus of -12 behind anterior commissure. That basically puts you within a couple millimeters of where we normally target in an average patient, given that there's a lot of anatomical variability. But what I just want to stress here is what the atlas looks like in terms of the anterior nucleus. You can see how medial it is. You can see it's right next to the ventricle. You can see it's next to the stria medullaris here. You can see the mammillothalamic tract coming up through this particular section. So this is projecting from the mammillary body and projecting into the anterior nucleus. And so not that this is remotely a consensus, but in general, this is the sort of starting point of where we think we might be looking for a target. But as I'll come to, direct targeting and seeing structures is very important. But 5 to 6 millimeters lateral, 0 to 2 millimeters anterior to the mid-commissural point. Here I have it as -12.5 behind anterior commissure, but that's approximately the same location. And then the Z is 10 to 12 millimeters above the mid-commissural line. This is one report of outcomes relative to where active contacts were located that gave benefits. And so you can see a bit of a heat map here. And what this demonstrates is basically the bottom middle part, or the ventral middle part of the anterior nucleus, just above where the mammillothalamic tract is projecting up to it. So this is some of our earliest data saying, yes, this particular location may be particularly critical. So this is maybe sort of our again, based on direct targeting, this may be our consensus of where we want to have an active contact. So, you know, just as an illustration of that. So again, the trajectory would be coming a transfrontal, going through the anterior nucleus, and then basically targeting to the top of the mammillothalamic tract, such that active contacts are right at that border between the mammillothalamic tract and the ventral anterior nucleus. That could leave, depending on where the contacts go, contacts on either side that could be used for local field potential recordings or closed loop stimulation paradigms. But that said, out of the Sante experience and other experience, we know there's actually a broad range of actual ACPC coordinates where the contacts landed, because the goal was to place this electrode on this location, not necessarily at a stereotactic coordinate. But again, approximately as a starting point, you know, where to start looking is 5 to 6 millimeters lateral, 0 to 2 millimeters anterior to mid-commissural point, and 10 to 12 millimeters superior to the mid-commissural line. So again, this is a histologic section from an atlas, this time in sagittal, and comparing it to an inversion. This is probably an F Gator MRI. We'll come back to more about the various types of imaging to use, but you can see that mammillothalamic tract coming up to the anterior nucleus. You can see this histologically. So the fornix is anterior because it comes over the thalamus, is coming coursing medial, and you can see it basically on the anterior side here, and this is going to go down to the mammillary bodies. You can see the mammillary body is out of plane here, but you can see the mammillothalamic tract coming back up. You can see the anterior nucleus of the thalamus. You can see the internal medullary lamina on the histology. You're not necessarily going to see that on all of your imaging, but this is, again, a sense of where we are targeting. This is showing it in coronal again. The other thing that has been suggested by Medtronic, I don't know that this is totally validated, but the outflow pathway of the anterior nucleus, or at least one of them, the main outflow pathway for the anterior nucleus is basically at the lateral superior border, the anterior thalamic radiation. So along the course of the anterior nucleus, white matter is coursing off basically laterally from the dorsal aspect of the anterior nucleus. And given their electrodes are coming from anterior to posterior and from lateral to medial, and you're targeting just above the mammillothalamic tract, that puts a top contact very on a more lateral aspect of the anterior nucleus, and that might give the opportunity to have more influence over those output tracts. Not totally validated, but this is one reason to consider the possibility that this particular approach, going from superior to inferior transventricular, gives you the opportunity to put electrodes both near the output and the input to the anterior nucleus. So a lead bias slightly laterally with the ANT may have greater potential for influencing these axons, as opposed to biasing medially. This is at least one study saying that where in a multi-center experience from Europe, where it attempts to place this via transventricular route versus a more lateral route that does not go transventricular. If you look at the transventricular trajectory and look at these red dots, these are all off-target electrode placements. You compare that to the extraventricular approach, and you can see there are a lot more of these electrode placements that were not quite on target anticipated. So suggesting that it could be harder to get the electrodes to fit or to go and accomplish the goals of where we want them to be via this extraventricular trajectory. That's not to say this is completely validated, but the point is just that there are two potential ways, at least, of trying to do this. So far, the greater experiences with the transventricular route. So far, the greater experience of outcomes that's been reported is with the transventricular route. And until we have other data otherwise, probably this is the wiser course. So compared to extraventricular approaches, we have improved access and target coverage, likely achieved via transventricular route. The extraventricular or lateral approach shows a higher miss rate, at least in this particular study. But that said, it doesn't make it easy. So when you start thinking about what you have to pass through, this looks like it should be not a big deal as long as every patient's brain reads the textbook, but as we all know, they don't. When you're doing deep brain stimulation and placing trajectories, we're often looking at the cortical vessels and sulci, and sometimes we're looking at the vessels that are just lateral to the ventricle as we're coming extraventricularly. But in this particular type of case where we're targeting that sweet spot right there through the dorsal medial part of the thalamus, our surgical window is we have to visualize and avoid these various vessels if we want to avoid an intraventricular hemorrhage. So the anterior septal vein, the thalamus striate vein, superior choroidal vein, often you can see the choroid plexus itself, is just anterior to, or just posterior to where we want to pierce the thalamus, the internal cerebral veins. None of these are things we want to directly encounter if we can avoid it. But you can see this sort of window in an idealized subject is where we're trying to place this. So you're encumbered on all sides. So that means your entry into the thalamus is restricted. You're aiming at a particular target that's a few millimeters down, the mammillothalamic tract. And now when you start to think of projecting that out onto the surface and avoiding cortical vessels, it means that instead of just sort of thinking of a top and bottom, we're sort of having to think of a top and a bottom and a middle that constrains our trajectory. So these are things to think about ahead of time and reasons to even consider pre-planning these cases, not just showing up the day of and realizing this is more challenging than you thought in an individual patient. This is showing it from laterally, the same idea. Again, mammillothalamic tract, that's the target. This is the sort of corridor between the vessels. This can be highly variable from one patient to another. Ventricular size is variable. Thalamic orientation and size and placement are variable. The location of these vessels are likewise variable because of that. So sometimes you're coming from a more posterior trajectory than this. Sometimes you're coming from a more anterior trajectory than this. Sometimes it looks on your two sides like they're vastly different trajectories in order to get through this window, but end up in a similar location. So these are all things to consider. And all of this is to stress that direct targeting and seeing what you're doing, especially if you have essentially real-time imaging, that information can be useful. Pre-op imaging, I have used some, but not all of these myself. Imaging always varies from site to site and what scanner you're using. But I've used the standard inversion recovery for years when I was doing this at Emory, and usually I'm able to see the mammothalamic tract and the anterior nucleus. It's useful to get this at 3T ahead of time, and then merge this with your stereotactic imaging. So I usually try to get preoperative 3T on any patient to maximize my imaging of this. This is showing the STIR image in coronal. And again, you can see the anterior nucleus, the mammothalamic tract. This is an MP RAGE MRI, which often looks most like a T1, but is a better, sharper image. We can often see the mammothalamic tract well on MP RAGE. Obviously, you're going to use your contrasted images to know where those blood vessels are, those veins that you want to avoid, and find your surgical window between veins and choroid plexus, but you're not actually on a T1 post-contrast going to see the target very well, so you merge that in. I've used F-Gator more frequently recently, and that can often give a nice picture of the mammothalamic tract as well. So the things we want to visualize, the ANT, the mammothalamic tract, if possible, the internal and external medullary lamina, because that is actually giving us the borders of the anterior nucleus, and we want to see those surrounding veins. And I would refer you to a variety of these publications that have reported on imaging parameters for seeing these things. This is just similar. So these are T1 MP RAGE in another subject. So again, the sagittal, the coronal, the axial, and the coronal. Doesn't always look this good, but if you can get 3T ahead of time, and sometimes even these patients have to be under anesthesia to get them still, but rarely. And then the STIR images again here, and more STIR images and an F-Gator. So this is a workstation shot from a ClearPoint system. So the system that I have used to do all my ANT targeting so far at Emory when I was there. So right from the start, I was already using a ClearPoint system, and I'll come back to that. And so it made sense that I would, since I needed to see the target, since I was doing direct targeting, I always did this this surgery with ClearPoint. I believe my former partner, Bob Gross, did a couple of these cases by a couple other methods. And obviously during the Sante experience, he did this with a frame. I think he's also experimented with doing it with ROSA. But for the most part, our experience at Emory was doing this with ClearPoint. So this is showing inversion recovery images. And one of this particular case is actually not my own. This is from a different site, but this it looks very similar. So you can see a ClearPoint workflow screenshot coming in. This is a sagittal cut, so you can see the intersection of the trajectory with the desired target that these surgeons picked near the top of the mammothalamic tract. You can see a little bit of the choroid plexus there. I suspect this trajectory coming in from a little bit lateral did not collide with that. Again, this is a projection. You can't quite see it where it's intersecting the thalamus, but again, you can see the bottom of their trajectory. You can see a little bit of the mammothalamic tract here. So you can see that they came in, intersected that target, and then passed a little deeper again because they want all of their contacts buried in thalamus. There's no reason to stop short and have any electrodes in the ventricle. I don't see any benefit to that. And that creates additional risk of the electrode backing out. This one is from my own case, not quite as pretty on the imaging, but a standard inversion recovery. You can see it, again, the mammothalamic tract here in sagittal. A little bit harder to pick up in coronal, but you can see a little bit of it right there being picked up on this particular slice. And you can see these little dot points right here of the mammothalamic tract in this particular subject. And already I want to point out, this is not symmetric, right? This is a standard axial, and you can see even in this patient, there's asymmetry of the orientation of the caudate, the basal ganglia, the thalamus. You can see this anterior nucleus looks like it's a little more anterior, and you can see the mammothalamic tracts are not symmetric. So again, already this tells you the importance of direct imaging in doing these types of cases if you're aiming at a target like this. You can see the large ventricle here. Ventricular size is going to be wildly variable between patients in this particular patient population. So having direct imaging and being able to see this is important. This is just another close-up of that case or a similar case. So again, these are anatomical views with an overlaid trajectory. This is the point at which the trajectory is intersecting with the anatomical view on the coronal, on the sagittal, and on the axial, but this is above target. But you can see just a little hint of the mammillothalamic tract right there and right there. You can see I'm coming down very close to it. You can see the mammillothalamic tract here. You can see intersection with that. As I said, it is useful to actually get the imaging ahead of time and plan these cases ahead of time because you don't want surprises. Individual anatomy can make the planning for this. Sometimes it's a breeze, and sometimes it's actually quite difficult to find an ideal trajectory where you're comfortable with the risk versus benefit. So, that process could take more than an hour. So it's useful to do this ahead of time. So the planning the case ahead of time leverages the imaging sequences that may not be available during the case. So you can get as many images as you want ahead of time. And you can identify potential challenges from the vasculature, anatomical asymmetries, or confounds that might come from the fact that these patients already have hardware. Maybe they've undergone previous craniotomies and have hardware in their skull, plates and so forth. Maybe they have a vagus nerve stimulator. So recognizing that those things can create challenges for imaging. So you want to work that stuff out ahead of time if possible. Factor the proximity of the entry points to avoid the collision of mounted ClearPoint bases if you're using this by the ClearPoint technique. What I mean by that is these trajectories can be becoming quite medial. So if you're using the ClearPoint system, those frames that sit on the top of the head, they can be quite close together. So you just want to be aware of how much space you have there if you're using that particular technique and how close you can get those ahead. So if you're going to use a ClearPoint technique, you kind of think ahead of time of where will my trajectories be and how will that affect where I'm going to put the frames. This case over here on the right demonstrates the asymmetry. If you look here on the sagittal, so on the left trajectory versus the right trajectory, you can see they don't look that much alike. Again, this is because we were limited trying to hit that target, limited by that sort of corridor on the thalamus, and then limited by the cortical surface anatomy. So the point is sometimes you can come up with a solution to this problem that looks on the whole asymmetric, but in the end you're getting electrodes where you need them to be. Another surgical consideration that came out of the Santé experience. Again, those surgeries were mostly being done with frames, but the point is you have a cannula that you're placing your lead, and the point is not to have your cannula stopping above target, but to actually bury that cannula into the thalamus so that when you deliver your lead, it's unlikely to deflect off the thalamus. So whether you're doing this with a standard metal cannula in a frame or whether you're using the ClearPoint's peel away sheath, the point is you want to bury that cannula as close to target as possible so that when you leave the lead behind, you're not actually trying to pass the lead into the thalamus and risking it bouncing off and being inaccurate, or worse, not even getting into the thalamus at all. And I know that I think my partner Bob had an experience like that. I don't remember the details, but I don't think he was using the ClearPoint technique at the time. So this can happen to anybody, but the key is really getting that cannula all the way down to the target. So a cannula that extends the target or just penetrating the ANT at least may help reduce deflection of lead into the third ventricle. That should say lateral ventricle. I'm not sorry, that's a typo. That should say lateral ventricle. Ensure all contacts are within the thalamus to anchor the lead and not within the ventricle. There's no reason to have leads in the ventricle. I guess one concern is, why would I place leads deeper into the thalamus than is necessary? Doesn't that create unnecessary risk? Yes, but I think the risk of these things pulling out is greater. And given that in additional, you may want to record from these contacts, I think the small amount of risk of placing the lead a few millimeters deeper is far outweighed by the potential benefits of avoiding the lead pulling out or the potential to use those contacts for other things. Intraoperative volumetric imaging such as O-arm, intraoperative CT, or MRI is highly recommended. And this is Medtronic literature. They recommend using intraoperative imaging. So again, if this is a transventricular approach, one solution to this is the ceramic stylet from ClearPoint, which I have used. So using a rigid ceramic stylet, it's because it's rigid, it doesn't deflect. It has a peel-away sheath to avoid deflection and penetrating the dorsal surface of the thalamus. I mentioned also that there's two versions of this stylet. One is basically rounded and blunt, and one is more pointed. There have been situations where I'm using this system where I'm worried about deflection. And as long as I know that I'm nowhere near vessels, I've used the pointed because when I encounter an interface, I know that that's not going to deflect. It will encounter that interface, grab it, and then I can go to target. So probably half of my DBS thalamic cases where I had a nice wide surgical window and I was not concerned, I used the sharper stylet. In other cases where I did have a concern where I was within a few millimeters of a visible vessel, just to be safer, I would use the blunter one, but both of these are acceptable. This is a surgical decision. The ceramic stylet provides excellent rigidity. You can actually feel it very well when you're placing it manually. So if you encounter something that's stiff, if you haven't passed the dura, you can feel that. You can push the dura. You can often even feel when you're passing through sulci once you've used this a couple of times. You can expect the optimal, especially if you're using the blunt, you can feel it a little bit better. You expect the optimal trajectory to require passing through highly vascularized regions. So again, which one of these you choose to use is up to you. Probably depends on individual anatomy. And then that peel-away sheath and ceramic stylet means you put it in, you image, you see that you're on target, and then there's no further passes because it's a highly accurate system. You pull out the stylet, you pass the lead, you pull out the sheath, you re-image if that's part of your workflow at that time, and the accuracy is good. So I'll come back to the data on that. So again, surgical considerations, bury the lead. We expect that these top contacts that are actually in the ANT would be the ones used for therapy. Contacts 2 and 3 are placed within the ANT to overlap the desired area for DBS, sort of modeled here in green. Contact 3, and this is the Medtronic version of the orientation. This Abbott and Boston have different labeling for their contacts. I'll remind you, they don't have labeling for epilepsy. But on Medtronic, it's contact 0, 1, 2, 3. For NeuroPace, it's contact 1, 2, 3, 4. For Abbott and Boston, it's 1, 2, 3, 4. The Abbott and Boston leads have split configurations, and these middle leads for quote directional stimulation. But just using this nomenclature, contact 3 is completely within the ANT. Contact 0 and 1 in this particular example would not be used for stimulation, but could be used for other purposes, such as recording if you're using NeuroPace or a Percept or PC+S or some other device. So this is an example of how you might use that if you were stimulating on contact 2, but you could use 1 and 3 for local field potential or for closed loop stimulation. So segue back to the ClearPoint system for those who are unfamiliar with it. This is a system I've used extensively for DBS for movement disorders. I've used this for all of my DBS for epilepsy cases. I've used this for a variety of NeuroPace cases, including thalamic RNS. I have also used this system extensively for laser ablation. This system marries very well with an intraoperative or interventional MRI suite, although some people use this in diagnostic suites with various air handling considerations and so forth. What you see here is basically the head that is draped. You can see a small exposure of the scalp and then this fiducial grid that's placed in an approximate location over where we're anticipating placing this mini frame and then ultimately doing the fine targeting. So this is referred to as the smart grid here, the smart frame. This has a base on it. There's a couple different configurations of the base. One is for mounting percutaneously for making small stab incisions or hovering over a small incision. And then there's another version of this where you make a larger incision. The whole thing mounts directly to the skull. So a surgeon preference as to how much of exposure they want. I most extensively use the scalp mount system in a small stab incision for laser ablation, or the scalp mount system in a small, about $half sized incision for DBS. There's a draping system here that has sort of an accordion such that the head can be pulled in and out into the scanner for imaging without pulling the drapes off. So there's a draping system that works well with this system. So everything you see here is the hardware and expendables, disposables involved in this case. There's also a computer workstation for the stereotactic targeting. Again, I mentioned the peel-away sheath. I use this, I think this is particularly good for, it can be used for ablation of hippocampal sclerosis to plant something without deflecting, but also in particular the anterior thalamic DBS cases. This is just showing a closer view of that grid placement. This is what my typical DBS case might look like. Actually, this is showing a burr hole configuration, which is the most typical way people like to do DBS. I actually don't even do that anymore for most of my ClearPoint cases. I usually make this size of incision and then put the scalp mount device on, but I drill a very small hole just with a twist drill that's available with this system. So just backing up here, so you can see there is a twist drill option with a 3.2 and a 4.5 millimeter bit that can be used. There's a metal stylet for piercing the dura if necessary. So that's what I typically do for DBS. I rarely do burr holes, even in the operating room anymore. But granted that this is the typical way people do things, this is what it would look like. You use the fiducial grid to determine where exactly in the scalp you want to mark it. You mark through the skin onto the bone. You make an incision around that. You expose that little point, and then you turn that into a burr hole with a hand drill. And then I often don't open the dura. I just pierce the dura. But then we'll make use of the burr hole and the burr hole mounting system, like a Stimlock ring or Neuropace's system. If I'm doing a twist hole, I will just lock it in place with a dog bone. Which is a little awkward to hold it in place, but there's a workflow for that as well. But anyways, this is what it generally looks like if you're doing a DBS case. So these are the frames on the head. This demonstrates how close these frames can be to each other. For instance, if you're doing relatively parasagittal trajectories, for instance, a GPI case with small ventricles for movement disorder, or in this case, ANT DBS, where the targets are relatively medial and the trajectories can be relatively medial and close to each other. So you just have to make sure that these two entry points are at least 5 centimeters or 6 centimeters away from each other in order for these frames to be able to fit on. So that's just something to consider if you're using this particular system. This is what the ClearPoint tower looks like. You can see these multiple knobs that allow you, essentially in miniature, what you can do with an arc-based frame. It's got an XYZ pitch and roll. Essentially, the Z is just passing down, but these are X, Y, Z, and pitch and roll. So I'm sorry, X and Y, and then pitch and roll functionalities to this. It can be done by hand, but you can see also there are these devices that attach to this so that when the patient is in the scanner, you can turn these devices and do very fine adjustments to your trajectory without having to move the patient. Those, how you change these is directed by the workstation as imaging is obtained. MRI scan sees these cylindrical targeting cannulas, which are filled with contrast agent as a fiducial system. So this whole device has fiducials built into it. So it's recognized by the workstation. The geometry of this is known. You make fine adjustments to target the cannula where you want, and then you can drill holes. You check to make sure they're still aligned. You pass your device through the dura and to target. In this case with a ceramic, you verify with imaging that these are where you want them to be, and then you replace the stylet with a lead through the peel away sheath, and then either you remove the sheaths and check your imaging after locking them in place, or there's various ways you can do it. So here, this is showing placement of a stylet down. In this particular case, you don't see the peel away sheath, probably because this was a laser case. But point is, this stylet is being placed through manually. You have that tactile feel of knowing if you're encountering anything such as bone edge or dura that would deflect you, and you can make adjustments as needed. You can go part way in image to make sure you're still on trajectory. See this little orange line down here is actually the desired trajectory you intended. And then you can actually see the stylet is following that exactly. You can get an error measurement of that if for some reason it's off by measuring where you're supposed to be at target versus where you actually are, and you can get a radial error. So in this case, an X error, a Y error, a cumulative radial error of 0.2. So essentially you're on target. And it will also give you depth in case you go past that. So the depth here is saying you're basically on target. So MRI with soft tissue imaging is the most reliable means to localize the final target placement. Again, this is showing using the workstation view for ClearPoint. You can see where this is an ANT target. You can see passing transventricular into the anterior nucleus. You can see the ceramic stylet here. This is on a T1 background, so you can't see the internal anatomy of the thalamus or the mammillothalamic tract. But on the workstation, you can actually fuse back and forth between what you're seeing live with your stylet and the fused image of the preoperative imaging. So you can compare this to your anatomical to know where you are. And again, you get immediate feedback of your accuracy and what you desired versus what you got. I would just say as an aside that this platform, I've used it for lots of other things. I've not personally done drug delivery, but we were doing this at Emory. My partner, Bob Gross, was doing this with the ClearPoint system. Obviously, we've used this for deep brain stimulation for a variety of indications. I've used it for very sensitive biopsies where accuracy is super critical, especially those very deep, tectogliomas and so forth. And then, of course, lots and lots of laser catheter placements. The advantage of this system, if you need direct imaging, is sort of one procedure, one room. The patient is in the MRI scanner and stays in the MRI scanner from the beginning to the end of the case. And so that has advantages for workflows when you compare this to other ways that you might place something in somebody's head and then go get imaging. Even in an IMRIS suite where an intraoperative MRI suite where you're placing something in the head and then you're going through a workflow where you bring in the MRI scanner and 15 or 20 minutes later, you have an answer as, did you get this where you wanted to be? Whereas with a ClearPoint workflow in an IMRIS or in an interventional MRI, you can put something in partially and 1 minute later, you have feedback as to how accurate you are. You can put it in the rest of the way, or you can make a correction if you need to. So you can make decisions, you can guide this, you can confirm, you can make changes. So I recently had to kind of dumb this down for my, because I was tasked with, I'm interested in getting the ClearPoint system in my new institution. So I'm trying to explain, when you're dealing with hospital administrators, they're like, well, you have a frame, you have an IMRIS, you have this, you have a ROSA. Why can't you do all these things with the stuff you have? And you can, but I try to explain the benefits and try to explain what I can do with something that I don't currently have. So I often refer to this as real-time imaging-based stereotaxis, and you kind of conceptualize it as steering the bullet. So you can see in almost real time, and depending on how you do this, you can make small incremental moves and have real-time imaging. The closest thing we have to that when we do other types of DBS cases is using a fluoroscope. And that only gives you some information. It doesn't give you soft tissue imaging. You could stop and get O-arm spins, but that takes time and is a lot of radiation. So when you're doing an MRI-based procedure, you can change your intervention in almost real time. So you can see and affect the intervention in real time and not afterwards. You can prevent and remediate inaccuracy. You can, because the interval between an action and a definitive imaging of the results is minimal and doesn't stop you. So again, apologize for dumbing this down a little bit, but my experience is when I do something with a ROSA or frame, you don't have that real-time imaging of both the hardware and the soft tissue at the same time. So you sort of put something in, and then you have some sort of imaging to investigate how accurate you were. And then you might make incremental changes by repeating steps, whether that's based on MER or a microelectrode recording or some sort of stimulation mapping or intraoperative imaging such as an O-arm, CT, or fluoroscope. But essentially you're taking an action and then seeing the result. The slight difference in ClearPoint, in my experience, is you can use this to essentially redirect things in real time. You can start to fire the bullet, stop, make sure that it's doing what you want it to do, and then continue firing the bullet after you've made some slight adjustment. You can either pull the stylet out, make a slight incremental change, and then put it back in to get to target. Sometimes you can even make slight movements. This would be off-label, but you can even make very slight movements with a partial insertion. But the point is you can do some of these real-time interventions that can make the difference between being on target or being off target by 2, 3, 4 millimeters. And again, not all targets are the same. People sometimes say, well, especially epilepsy surgeons that don't do DBS, I put electrodes in the hippocampus all the time. What's the big deal? What's the big deal for laser ablation? Why do I need special ways to do this? What's the big deal for putting a therapeutic lead in the hippocampus? No big deal. There's a huge difference between just hitting the broadside of a barn and getting an LFP signal and actually putting something exactly where you want it for therapy. And so that's just something to consider. The ANT, while it is a very feasible target and has good benefits, there are aspects to it which make it a little bit more challenging than just a standard stereotactic placement. So these things have to be considered. And one other example from ablation, which is sort of a blow up of how this sort of real-time imaging and remediation can take you from potential failure to success. This is just an example of a case where I was doing a laser ablation. And the reason I'm showing you a laser ablation instead of a DBS is because I don't have any examples of, where I risked failure during a DBS case with ClearPoint, because I always got what I wanted. It's so rare that you have something that's off target by even a millimeter or more that I don't even have images to show you examples of that. But for example, here where I was using ClearPoint to try to do a hippocampal sclerosis ablation, in this case, there were some other constraints on my entry. You can't see it here, but there's actually a shunt on this side that was occipital, so I had to work around a shunt. So I was placing a device, and it was a sclerotic hippocampus. I ended up deflecting slightly from my desired trajectory. I went ahead and bladed, but what I got was this, where here's an outline of what I wanted to get. This is my hippocampus, and I was able to ablate part of the hippocampus and part of the subiculum, but look at all this extra target, the medial aspect of the entorhinal cortex, some of the head of the hippocampus. And while that might have been good enough, to me, that was, risk for failure. So the fact is, with the ClearPoint system, all I had to do was pull the device out, redirect slightly, go right back in, and then complete the ablation. And it without having to take the patient back to an operating room environment, without a whole lot of workflow changes, added, probably an hour to the case, but got the job done. And the point is, this type of hardware and system allows you to consider these sorts of interventions. Again, if you're thinking about how to do these things with different devices, when I think about the ClearPoint system or direct MRI guidance, I think about doing things a little bit differently. So multiplex laser cases, like the examples I just showed you, direct targeting for DBS, which is especially, as I've outlined, especially important for epilepsy. You don't have MER, other things to fall back on. You don't have an awake patient to tell you you're getting a tremor benefit or so forth. So direct targeting is everything. This device can be used for other things, drug infusions and so forth. And I compare that to some of my other technologies that I routinely use. I don't want to go into too much detail here, but again, these are all things that I have used. And so I sometimes think about what I use them for and what are the advantages of each. The applications of a traditional frame, indirect target DBS, simpler laser, biopsies. My robot I use for SCG, simple laser, or sometimes high trajectory number of laser cases where accuracy may not be as critical. Might use it for biopsies. I've used 3D printed frames, the StarFix system. That is a highly accurate way to do things, but might have some other disadvantages for those who have used it, but is a very accurate way of doing things. And that can be used for indirect targeting DBS, SCG biopsies. They have a workflow also for direct targeting. Frameless neural navigation, I would probably not use it for any of these things I've outlined, except for maybe biopsies. It's just not routinely accurate enough. And what I mean by that is, say, a Vertec arm or that sort of contraption where you're using indirect frameless neural navigation imaging. By comparison, a direct MRI guidance frame where I'm using it for biopsies, direct targeting DBS for epilepsy, a multiplex laser, gene therapy infusion, in the future, perhaps clot evacuation. There's differences in expendables for these things. The things to note are a 3D printed frame costs money, and a ClearPoint system, the devices have expendables that cost money. All these things have some expendables, but basically the major device is expendable for 3D printed frames and for ClearPoint. Accuracy, in my personal experience, is absolutely the highest with ClearPoint because I can see what I'm doing in real time, alter it, and make sure that by the time I get to my target, it's perfect. Whereas with all these other things, I go to target and then check. And they may be very good for getting me at target or close to target most of the time, but I won't know that until after. And so in my experience for these types of things, the highest accuracy I'm going to get is with ClearPoint, but it's almost because you're cheating, because you have that advantage of real-time imaging. But I'd rather cheat and win. So the sheath cannula, we talked about those issues. For a traditional frame, you have a cannula you can use. For 3D printed frames, there's a cannula you can use. And then for direct imaging, we have the peel-away sheath. Only the ClearPoint gives you that real-time imaging advantage. There is a technical support involved with ClearPoint if you're using that system. Bone fiducials, we talk about the need for that. That's often used for doing a stereotactic robot. And of course, you need a bone fiducial system for 3D printed frame. You don't need to place bone fiducials ahead of time for direct MRI guidance. So this is an example of actual accuracy of the ClearPoint system versus the ROSA when I was using this for laser ablation of the corpus callosum. So not exactly the same thing. And the reasons to expect that this would be a more challenging case to get accuracy. They're very long trajectories. The trajectories can be skyvy compared to bone. But you can see here in doing the same type of case, when I use ClearPoint versus ROSA, I got much more acceptable accuracy with the ClearPoint system. Of course, the incisions are small, whether it's a stab incision, even that's excessive, having 3 staples. I usually just close it with a single monocrystal suture, or whether you're having more linear incisions for DBS, the incisions are small, but that's the case for all these approaches to DBS. This is just another example. I want to move on because I'm probably running short on time. So I want to move ahead. Again, this is, seeing our stylets at target. There are examples where I have placed into ANT from a prone position. Those are particular examples where I was using NeuroPace in patients that essentially primarily needed hippocampal leads placed. You can see this is a patient that had a temporal lobectomy, failed, and we recorded and found seizures coming from the contralateral hippocampus. And so I placed 1 lead in the hippocampus and 1 lead in the ANT. This was off-label and prior to the approval of DBS for depression, or DBS for epilepsy. But in that situation, because I was placing a lead from a posterior trajectory, I chose to also place the ANT lead from a posterior trajectory. And this is before publication of a lot of the more recent experience suggesting maybe this isn't the most desirable trajectory to get what you need. But the point is it can be done, and it can certainly be done with a ClearPoint system. So this is an example of me placing a lead in the ANT from that more posterior trajectory. This was also a transventricular trajectory. This is the lead in the hippocampus. And so this is what a system looks like afterwards. So I think at Emory now we have 4 of these patients where we've done this sort of approach. This is, I would just mention, again, I mentioned this before, but when you're placing leads in the hippocampus for therapy, it is also highly desirable that you get those contacts exactly where you want. So ClearPoint has advantages for that as well. I've had experience, Bob Gross has had experience where we've tried placing RNS leads with robot, and while it usually works just fine, we have all had experiences where it deflects. You get an intraoperative O-arm spin, and it's often in the ventricle. So to me, ClearPoint is a great application for placing leads in the hippocampus for epilepsy as well, and such as in this example where it was both ANT and thalamus. Now, doesn't mean when you pass through the ventricle, you'll never get a complication. So here's an example of the last RNS that I placed that was both a hippocampal ANT case. And you can see I even got a little IVH here. Now this patient did just fine. There was no repercussions to this other than I admitted to the ICU and watched for a day. But the point is, even with all of this technology and all of these advantages, you can still occasionally get that intraventricular hemorrhage. So this is another advantage of having the intraoperative imaging. I knew in real time when this started to happen, and I knew when I stopped, waited 10 minutes and imaged again, that it was completely stable and I did not need to abort the case. So I would not have had that information. Now, granted, maybe you don't want to know that information, or maybe you do when you're doing this case, but this was an advantage to me. I saw in real time what was happening. I knew that it was small, I knew that it was stable, and I knew I could finish the case. So I finished the case, the patient did fine, and has had no long-lasting repercussions of having this small intraventricular hemorrhage. This is my personal data from the ANT trajectories, from Emory. And again, so you can see these prone cases versus the targets all, almost exclusively within that 0.5 millimeter. So very good. So granted, we only have a few minutes left. I want to talk about one other indication. I'll go through this a little faster. So this is a patient, 25 years old, seizure onset documented age 3, lives with his parents. He has daily seizures. His MRI is normal. His PET scan is non-localizing. Scalp video EEG shows generalized spike in waves. He has generalized seizures, drop attacks, and injuries. His neuropsych shows bilateral dysfunction in multiple domains. So this is not the same type of patient we were talking before. This is a patient with likely Lennox-Gastaut syndrome or symptomatic generalized epilepsy. So There is an off-label use of DBS in the thalamus for epilepsy, and that's the centromedian nucleus. This is an emerging target, especially for Lennox-Gastaut. There have been multiple case series about this. There's an ongoing clinical trial in Australia. This is a paper coming from that group. I'm sorry, this is a paper, this particular one is from the European group, one of their case series, but reporting targeting of the centromedian nucleus for generalized epilepsies. They have initially used microelectrode recording and stimulation, but I would argue that the value of this is still controversial. This is still probably a direct target. This is showing their results from that case series, suggesting that the patients with generalized epilepsy did the best. In that group, I forget the N number, but an 80% reduction in seizures. This has been very similar to our own experience at Emory, whereas patients with a non-generalized but frontal lobe, hard to localize frontal lobe epilepsy did not fare as well. This is a more recent study from John Archer's group in Australia, the group that's doing a large clinical trial of this. And so they reported, this is a good paper to look at if you're interested in the direct targeting of CM and how to locate it, the best imaging for it. So this is just showing the atlas location of the centromedian nucleus. We don't have good consensus coordinates for this. It is highly variable in different patients, so that makes direct imaging all the more important. And this is an evolving field. But in this particular paper, they report the use of MP2 RAGE, which I was not yet able to obtain at Emory before I left. So I've not tried this personally. This is a convergence of 19 patients at 3T, so that's why it looks so pretty. But this is showing you in general what the average anatomy of this particular area looks like. So centromedian nucleus. This is in my own atlas, essentially where I'm looking. So about a centimeter off the midline, just a few millimeters anterior to the posterior commissure. So you can see this is a very inferior, very posterior target. So the X, 7 to 10 millimeters lateral to midline, 8 to 10 millimeters posterior to the mid-commissural point, so almost at posterior commissure, and anywhere from 0 to 3 millimeters relative to the mid-commissural line. But this is not by any means a consensus. There's a lot of anatomical variability. This from that paper is just showing 6 individual subjects and where they located it to highlight the individual imaging in these patients and the individual variation and how they modeled where they modeled the CM to be. This is showing where they located their electrodes for therapy relative to the CM. And this is just demonstrating that if you think of using the Shalton, Brannon, Warren atlas on the Stealth, that could steer you wrong. As we know, that atlas is not a conformable atlas to a modern degree. And so just placing that atlas on 2 patients shows just how wildly useless it is when trying to locate CM in a couple of individual patients. So I encourage you to look at that paper if you're thinking about this target seriously. I have done several of these cases at Emory. We had an experience when I left of about 7 or 8 of these. So this is a ClearPoint case of my own where I was targeting that location. Again, you can't see the target that great, even on these other images we've shown, but you can, based on some local landmarks and a little bit of indirect, okay, I expect this to be a few million, based on that consensus I reported in the atlas. You can see some subtle imaging here, but again, this is an area in need of further investigation. We tried direct targeting, we tried microelectrode recording, we tried stimulation. We did not find that MER or macrostimulation told us much about where to put this, but some other studies have reported using that information. I think that's an area that's still actively being investigated. I ended up, by the time I had left Emory, I was doing this all direct targeting with ClearPoint. So again, you can see the approximate location of the CM here on this coronal and here on the sagittal. And you can see it with the T1 post contrast relative to the posterior commissure. You can see them just anterior to the posterior commissure and about 10 millimeters off midline. And you can see what a trajectory looks like for this particular target. And I'm going to skip through this. That's just showing the placement of the ceramics. Again, there can be some variations in asymmetry of anatomy that we take into account. So in conclusion, direct targeting with intraoperative MRI is an excellent way to achieve technical success in thalamic DBS for epilepsy. The ClearPoint system, in my experience, provides advantageous workflow and accuracy for focal or partial epilepsy with focal impaired awareness with or without secondary generalization. Medial, temporal, or neocortical well-defined targets we often in my personal practice have had a preference for RNS, but for medial temporal or frontal with poorly defined targets or multifocal, or where patients prefer a little less effort on their part, where they don't have to upload data, then often we've gone to the anterior nucleus of the thalamus. For generalized epilepsy, VNS is the least invasive option with well-demonstrated benefits, but there are a lot of patients out there that are still seizing a lot, and those patients can be considered potentially off-label for centromedian nucleus DBS. This is an emerging application. I was just jotting this in there and I didn't get to finish it, but what I started to put in here just before this session started was I was looking back at our Emory experience. We reported an abstract at ASSFN last year. Since post-approval implants placed between May of 2018 and July of 2019, we had 7 ANT cases. We were doing between 2.8 and 6 volts. We were starting with the standard Santé stimulation parameters of 145 hertz. And what we saw in these patients was 71 to 100% reduction in seizures for a median of 77. I didn't quite get to finish writing it down here, but we had done 6 CM cases. Our stimulation parameters were 2.5 to 5. We were either using 60 hertz or 130 hertz because both of those are reported as beneficial in the literature. And I didn't quite get it written down here, but our median reduction in seizures in this population was 80%. So far, our initial experience with these targets at Emory was very good. Again, that's just one location, one series, but this is consistent with the information that we've been getting from multiple different centers that are starting to do these targets. And the last I heard from Medtronic, at least with their systems, they have placed, since approval, they have placed 200 DBSs for our epilepsy in the anterior nucleus at 40 different centers, but I'm sure there's a lot more being done with other people's systems, such as Boston or Abbott, that's off-label. So there's probably a lot more being done than we know of. And happy to stop there and take questions.
Great, Dr. Willie, thank you. That was really an excellent talk. I think many of us appreciated both the depth, the level of nuance, but also some of the messaging that is really helpful for people who are getting introduced to ClearPoint for the first time. We have a few minutes here. Really, all of our attendees are still logged on, and a couple of questions have come in. So you discussed the importance of contact placement and even orientation. Are you able to make depth adjustments post-implantation with MRI guidance? And can you describe a little bit about that process?
Yeah, that's a great question. So the question kind of hinges on whether you can do an MRI scan with the lead in place. And the answer to that is yes, you can safely do that. And different companies have labeling for that. Medtronic especially has done the most over time, have labeling for doing an MRI scan with a lead in place. I believe somebody from NeuroPace, please correct me if I'm wrong. They did not used to have labeling for that, but I believe they do have labeling for that now. That said, at Emory, we always imaged the lead in place, so we could make adjustments. And usually that was just a volume T1 image or volume MP Rage image to localize. We could actually see individual contacts. So I will go back to, say, one of these. Find it here. I'm just going to pull up one of the images. I'm just trying to find the RNS because that shows the leads well spaced out. Okay, so you can see here, for instance, on our RNS, where leads can be very widely spaced, you can easily see the contacts. And this is a very old case. We have since improved our imaging even more so that you can get rid of some of this artifact and see the soft tissue relative to the contacts with a little less bloom. This became really important when we started using Abbott and Boston leads because they're more complex leads with more contacts. And so for us to actually see the contacts, we had to adjust some of our T1 parameters. And for that sequence, we can get it from the physicist at Emory, but also I believe Abbott distributes this, because they helped us do some of that work at Emory. But you can safely image these things, but you may be at a center where your physicist is not excited about that. So you definitely have to go through some hoops to do that. But to answer your question directly, once you put the lead in, you can get an MRI scan if you have safe parameters, safe imaging, and you have your radiology and physicist on board. And based on that, you can see where your contact is relative to where you want it to be. And if you're off by a millimeter along that Z, you can make adjustments before doing your final locking in of that lead. even after you think you finally locked it, whether it's with dog bones or with a stim lock ring or with a cap from RNS or whatever you're using, the various versions that Abbott and Boston have, you can image again, if you're using the appropriate safe imaging parameters, and verify that that lead is still where you want it to be and that there has been no movement along that Z. So yes, ClearPoint does facilitate that, but you may have local rules and regulations that govern some of that. And there are some imaging types, T1 base, that are better for doing this than others. So that has to be worked out locally. Excellent, thank you.
And you showed the poster with some of your center's outcomes there towards the end.
Yeah, sorry.
When it comes to, I'm sorry?
Sorry, I didn't finish putting in all the data before the session started.
No, it's great. It's helpful because, that's after it's all said and done, taking a look back. But when it comes to programming specifically for epileptic therapy, how does some of the accuracy or the imaging that you have impact that process?
Yeah, so I think, our experience at Emory was still rather new. The epileptologists were just getting, like I think everyone's going through, epileptologists are not used to programming DBS, right? They've been getting used to programming RNS. And so unlike our movement disorder colleagues who for many, many years now are used to having reconstructed locations of their leads relative to very well characterized targets and knowing how to use that for programming, it's been more of a evolving field on the epilepsy side. First with the RNS experience, because these leads were not necessarily always ending up in a very well-defined target. It wasn't always an STN, right? Sometimes it was in the hippocampus, this part of the hippocampus, that part of the hippocampus. There was no right answer necessarily as to where these things were supposed to be. But that has evolved with the neurologists and with various imaging that has allowed us to place these things in reconstructed atlas maps for us to help guide where we want to be. So the point is, I think, if you have this lead placed and you know where this lead is on postoperative imaging, it may be as simple as a postoperative CT scan that shows where your leads actually are, reconstructed to a preoperative MRI showing where your target is intended to be. You would start by programming and stimulating in this particular target. You would stimulate on that contact that is at that ventral part of the ANT closest to the mammothalamic tract, right? So that's how that could be used to guide the initial stimulation of this. If you were targeting the CM, sometimes, if you get side effects on certain contacts, in our personal experience, stimulating on the bottom contacts that maybe be just outside of CM, getting particularly inferior or medial, sometimes we get some changes in arousal. And so we found that if the patient was feeling something, we could stimulate on contacts that were higher and the patients would do better. So very limited experience, but having some imaging that doesn't necessarily depend on the ClearPoint system per se, but having postoperative imaging that tells you where these contacts are relative to an atlas gives you some initial starting points that the neurologist can use to program when they're first picking their contacts. And they may also try broad stimulation where they sort of spread their stimulation across multiple contacts and then only limit it if they run into side effects of some sort. I think this is still an evolving field, but in general, for ANT, you would start by stimulating in the contact, the one or two contacts that is clearly in the anterior nucleus above the mammothalamic tract. And that would be based on your preoperative compared to postoperative imaging.
Sure, that makes sense. Having that imaging directly to see it helps, I would think. You touched on this, and this is our last question before I think we'll start wrapping up, but you touched on this briefly during the talk, but it's an important consideration. Do you need a 3T intraoperative scanner to get the image quality sufficient for visualizing thalamic anatomy in real time? And what are some of the trade-offs between a 1.5?
Well, all I can say is I never had it. So I did all these cases at 1.5. There are advantages of 3T. Obviously, you may get better image quality. There's a disadvantage of 3T for real-time stereotaxis in that there's actually more distortion. So what you're seeing may not quite reflect reality in terms of some of the distortions that occur. So that has to be considered. So my workflow was typically to get preoperative 3T and then merge that to a real-time image at 1.5 and then compare those things to make sure that using the 3T to see where I wanted to be and the 1.5 to see where I actually was, between those two, I did well. So no, it's not necessary to have a 3T to do this. That said, people are using ClearPoint at 3T and 3T interventional scanners. They're using ClearPoint on 1.5 scanners. So you don't have to have 3T, but it is useful to have 3T imaging preoperatively, at least, for maximal visualization of where you think you need to aim. And the workstations, the ClearPoint workstations and other stereotactic workstations allow you to merge that historical imaging to the newer intraoperative imaging so that you have all that information.
Excellent, thank you. If you don't mind, stop sharing your screen. We have one thing to show here, but really, again, your talk was excellent. I think it provides a game plan for those who are considering these targets for the first time. And this will be available for people to view on YouTube afterwards. I did want to quickly mention, just because each target really is its own consideration, we wanted to start offering a series of reference compendiums on a target-by-target basis. The first one that we're putting out is all about the anterior, the nucleus of the thalamus. And this was something that we've been putting together. Kara Kittelberger, who manages our clinical team, worked across various stakeholders with input from Dr. Willie, for instance, to put together a nice booklet that serves as either a good first step or a reference guide for anyone who is seriously considering these procedures. As it says, please reach out to us at info@clearpointneuro.com, and we'll be sure that you get a copy very soon. So with that, I'd like to wrap up for the day and say once again, thank you to Dr. Willie, as well as the many others who contributed to delivering this event today. All of us here at ClearPoint Neuro are available to support you. Please do not hesitate to reach out. We hope you enjoyed spending some time with us today and look forward to seeing everyone more in the new year. Thanks again.
Thanks, everyone.